One to the latest in our webinar series, Getting to the Heart of Fertility. Tonight, myself, Samir Jatkar, and my colleague, Dr. Hugo Fernandes, will be talking about the other half of the fertility equation, the males and male factor in fertility, in the recognition that it takes two to tango. We need healthy gametes and from both partners in order to have successful fertility treatment and a successful pregnancy. So without further ado, I'm going to hand over to Hugo, who's going to take us through the first part of tonight's presentation.
Well, thank you for that introduction, Samir. And for some of you that have seen these presentations before, you'll recognise these graphs, but they're really important graphs. So fecundity is the ability of a couple to get pregnant in any 1 month, and generally that's considered to be about 20 to 25%. And that's true for the start, for the first 3 or so months, but unfortunately it does fall over time, sort of recognising that most people get pregnant reasonably quickly and early on. And if you haven't been able to achieve that, then your chances do fall over time. But generally about 80 to 85% of couples will be able to conceive in the first year. So subfertility is the failure to conceive after 12 months of regular and unprotected intercourse, and in a under 35-year-old patient. And subfertility represents about 15% of the population. Again, 85% of people will get pregnant within a first year. And the causes are pretty much evenly divided amongst sort of a joint male and female, about 30% male and about 30% female. And we're obviously going to focus on the 30% of male today. Age is a very important factor in fertility, and female age in particular is probably the biggest single determinant of fertility in a couple. In that purple line that you see at the bottom, you can see that things are pretty good up until about age 30, and then from there on they tend to gradually fall. The majority of that fall is based on female age, and it's actually the result of women being born with all their eggs and never growing new eggs. Guys, on the other hand, many people don't realise this, but guys on the other hand produce sperm all the time. And this is something that they do throughout their life, from puberty onwards. And if Hugh Hefner or anyone else of that age is to go by, they can produce it until death. The blue line is sort of the male fertility, and you can see that that's pretty even on this graph at all ages. So how does it all work? Well, this is a kind of diagram that we have at medical school explaining it all, and this is all a bit too fancy for me. So we'll just down to the basics. And the basics for a guy are the testes. And testes are about the size of a walnut. They're about 5 centimetres long. They weigh about 35 mils. They contain about 800 mils of tubules, and within those tubules, sperm develop. And the testes have two main functions. One is to produce testosterone, which is the male hormone that helps, that makes men develop into men and all the male characteristics. But the second thing is it produces 200 to 250 million sperm a day. So they do a lot of hard work. Spermatogenesis, or the growth of sperm, formation of sperm, takes about 70 to 75 days. So it's about 75 days to grow a sperm, and then it takes about 3 months to get a fully mature sperm. It's also, that incorporates the time that it takes to go through that 800 meters of tubules. It's influenced by hormones in our brain, LH and FSH, the same hormones that are found in females. And of the 250 million sperm that are produced every day, maybe 100 million of those are actually viable and useful. It's for this reason that if you have a semen analysis that's abnormal, my normal thing is to say repeat it in 2 to 3 months, because it does take that long to get a new batch of sperm through. So the healthy male. So this is typically what we're starting off with, and the whole point of today's talk is to see how we can improve your chances with more than Old Spice, or if you're a young fella, more than Lynx, and how do we turn you into a Brad Pitt. As always, our conversation starts with lifestyle changes. The main reason is that they're easy to do, they're straightforward, and they actually, for guys, make quite a significant difference. The main issues are drugs, and all of these things tend to reduce sperm quality, lower sperm count, and affect the sperm motility. The good news is that they're all very largely reversible. So if we start with smoking, smoking damages DNA. So all the chemicals, the many thousands of chemicals in smoke, have a negative effect on DNA and damage it. They also lead to impotence because of their effect on the cardiovascular disease. Alcohol has a very similar effect, and it's related. So you get a decrease in libido, an increase in estrogen, and yes, guys have estrogen as well, and this is what sort of leads to man boobs. The alcohol, which often goes with smoking, together increase impotence, and that's obviously brewer's droop, and no one wants that. Caffeine has a negative effect, and steroids and party drugs always have a terrible effect. Steroids in particular have the opposite effect of what many people think. Steroids being testosterone, often used to bulk up, become more manly and more masculine. It has a direct opposite effect on testes. It makes them smaller. It kills off your sperm. And the downside is that when you stop it, it can take many months, to occasionally years, to try and to reverse this, if ever they go back to normal. Weight and BMI is an issue we all struggle with, especially coming out of COVID, and I'm not sure yet how long COVID can be used as an excuse for being overweight. I'm going to try and push it for as long as possible. But you want to try and aim for a BMI of about 20 to 30. Larger men generally have poorer sperm. Again, that's because they generally have a lower diet. They often drink more. How do we reverse this? Well, exercise. Exercise can be taken to the extreme though. So exercise is 30 minutes or so of moderate exercise per day should do the trick. If you're doing 200-kilometre bike rides every second day, then you're doing way too much, and that's going to have a negative effect. The same thing, sitting around doing absolutely nothing is of no benefit. We always encourage a good, healthy diet. Just keep up with shellfish, poultry, some cereals. It's all the normal stuff that you find in the food pyramid. But essentially, get up and get moving. If we move on to sex, so the optimum time to be having sex is in the few days before ovulation. You can use different apps and programs or urine testing to determine when ovulation is, but studies show that if you have sex in the 2 to 3 days before ovulation, you have optimum chance of getting pregnant. And the reason for this is that sperm can survive for 3 to 5 days in the tubes and the uterus, and they need to already be there waiting for the egg. The egg can survive for 24 hours. So if you have sex in the 2 to 3 days leading up to ovulation, then that's quite a few sperm that get to swim through and wait at the end of the tube for this egg to come out. So it's very much about the timing. You can have sex whenever you want, but unless it's in this window, it's not going to help your cause. So what about frequency? And this is a point at which everyone sort of giggles during the consultation. The common thought is that it needs to be daily, and that improves your chances. And it does a little bit, but those couples that have a second daily intercourse only have a slightly smaller chance of getting pregnant. So overall, it's a minimal difference. What does change, though, is stress levels. Those couples that have a daily intercourse or feel like they have to have daily sex have much higher stress. And the reason is it only takes missing out on one occasion because you're tired or have a work function or something on for you to feel that you've let the team down. And the reality is you don't need to put that much pressure on yourself. Second daily is just as good and achieves a similar outcome. It's also much more doable. As I've put there, you're not a machine. Lubricants often necessary either for pleasure or to make things easier. Just make sure that you're using one that isn't actually making it harder to get pregnant, because many are detrimental to sperm. So there's a couple there. And if you go to a pharmacy, they'll usually have one or two available. If you go to a sex shop, they'll often have a couple available as well. Position does not affect your ability to get pregnant. The sperm is very, very good at finding its way through the cervix, through the tubes to that egg, and it really does so within sort of 15 minutes. So, fancy positions don't help the situation at all. So just as long as you're not breaking anything, it's not do whatever works for you. Interestingly, the female orgasm is important. Studies show that women who orgasm, their uterus contracts and seems to sort of pull the sperm in to the uterus and towards the side that ovulation is going to occur. So, guys, do your best. Men's supplements. So this is something that my patients have raised regularly, and do so more and more as we're sort of getting into supplements and natural intakes and foods and being healthy. So, and there's a huge market for this. It's multi-billion dollars for supplements for all areas of our life. I've put on the screen some of the more common ones. So Menavit is the male version of the Alavit, which is the common female multivitamin. Profertil is one that I've prescribed. You don't prescribe these actually, but I've recommended that patients take. And Profertil was available via mail order until a couple of months back, and it got stopped. It's no longer delivered to Australia. And so I found Fertilsan M, which is very much the same as Profertil. It's the same mix of medications. So if you look at them, all men's multivitamins or supplements tend to have the same things, and they're essentially a combination of antioxidants and some trace minerals, the most common being those. So CoQ10 or coenzyme Q10 and vitamin E are quite strong antioxidants, and zinc and selenium are trace minerals. They're all necessary for good quality, healthy sperm, but you sort of have to have something wrong for these to be of any use. They're certainly not going to harm your health or sperm health, but you could just be wasting your money. I know that if I have a couple where sperm is an issue or of a lower quality or lower count, I'll often recommend one of these as a way of trying to improve it. And if you look at the ingredients on them, they're all essentially the same. There is variation in quantities, but this isn't the thing that's going to, all of a sudden make you fertile. It will help, it will improve, but this isn't the be-all and end-all. So some other stuff, tight underwear and heat, spa, baths, saunas, and heat in that area. All of that is relevant. So we know that heat makes sperm counts go down. As in the earlier slide, the testes are about 2 degrees cooler than the rest of the body, and any heat is sort of detrimental to sperm. Tight undies works on the same principle. These are minor things that are probably not the cause of your fertility issues. So we'll be moving on to sort of to some more fancier stuff with Samir in a minute. My general advice is to help your fertility, you need to start young, you need to eat healthy, you need to have a really good and normalized weight, quit smoking, reduce alcohol, tea and coffee, a regular to moderate amount of exercise, sex is good, and have fun. Try to relax. So with that, I'm going to move you on to Samir, who's going to present the next part of our presentation on the tests and some treatment. So Samir.
Thanks, Hugo. So yeah, we'll be moving on to the tests and treatment for male infertility. As Hugo alluded to earlier, it is a fairly complicated pathway to the creation of sperm. But broadly speaking, in terms of when we find problems in the sperm count, we can divide them into obstructive problems, so a physical problem of sperm exiting into the outside world, or non-obstructive problems, so that whether that's a reduced sperm count or total azoospermia, meaning no sperm in the ejaculate. The most often cause that we find is associated with age, or we don't get an answer. And sometimes that's a bit frustrating, but usually it is also reassuring that we exclude any of the more serious causes, and I'll go into some of the tests that we can do. Also, we do see people with normal sperm counts who have erectile dysfunction, and then there's a problem in achieving intercourse, not being able to ejaculate, or in fact the ejaculate, instead of coming out into the outside world, going backwards into the bladder, a condition called retrograde ejaculation. So, as I mentioned, the non-obstructive causes can be of a number of different types. You've got previous exposure to severe infection, and the classic is mumps. Orchitis is inflammation of the testes, and often this could be a febrile illness when a person was a child, and that can have long-term consequence. Then there's the genetic disorders that are the result of chromosomal or microchromosomal deletions. Varicoceles, which are dilated blood vessels around the testicles, heat the testicles, which isn't ideal for sperm production, and can be associated with the build-up of toxins in the testicles. Ultimately, the brain is the master controller, and sometimes neurological and endocrine problems, so problems with the pituitary gland and the brain itself, can contribute to male factor infertility, although that's pretty rare. The chances of seeing this, is fairly uncommon. So when we come to look at the tests for the male side of things, the basic test is the semen analysis, and the three most important factors that we look at are the count, how many are there, the motility, can they swim into the right place to do their job, and the morphology, or the shape. And it's important to remember that semen analyses are dynamic, so if it is abnormal, you do need to repeat it in 6 to 8 weeks just to work out if this is a temporary problem. For instance, if the male has had an intercurrent infection or other sort of stress, and that's reversed, you may see recovery in the semen analysis. So important to repeat that after an abnormal finding. When we look under the microscope, we see a number of different problems. Sometimes we have a low motility, asthenozoospermia. Sometimes we have a low number, oligospermia, and sometimes the abnormal morphology, which is teratozoospermia. And on the right, you can see there's just all sorts of different abnormalities that we see in the shape of the sperm. And in fact, to be considered compatible with fertility, men only need 4% or more of the sperm in their ejaculate to be the normal shaped sperm there in the middle of the picture, to be considered compatible with normal fertility. So, as mentioned, we can have low total count, we can have a low motility, morphology, we can have a total absence of sperm, which is azoospermia or aspermia, which is often seen in retrograde ejaculation. So, if you get an abnormal result, apart from repeating it and seeing if it is if it's a temporary or an ongoing problem, it comes all back down to the lifestyle changes that Hugo mentioned. You have to optimise your diet, exercise, and supplements, and that's the number one factor that we look at in terms of optimising health. And of course, if it is a persistent problem, that's the point where people find themselves with doctors like myself and seeing a fertility specialist for review to see if we can find any underlying cause. Apart from the standard semen analysis, there is the option of doing DNA fragmentation testing. Now, this isn't a standard test, and hence it is controversial who to test, what to do if they're high. I've seen the circumstance of low sperm counts being associated with high DNA fragmentation, but sometimes you do see it even with normal sperm parameters on a conventional semen analysis. If the if the DNA fragmentation is high, unfortunately, the kind of interventions that we have to redeem that come back to lifestyle, which to some degree we should be doing anyway. And then in terms of supplements, all of those antioxidants that Hugo mentioned have been associated with improvements in DNA fragmentation in those with abnormal sperm parameters. It hasn't been shown to necessarily help those with normal sperm parameters, however. So the role of DNA fragmentation is probably secondary to the standard conventional semen analysis, and it's really for those who need a little bit more investigation of potentially poor outcomes from IVF treatment. Coming back to the broader problems we see in the male, erectile difficulty, so failure to be able to achieve intercourse. There are very effective treatments now, and the best port of call initially is to see your GP. Now, there are online clinics and people sort of sending remedies over the internet. We would suggest to avoid those. Your GP is really in the best place to do the full evaluation, and it's simply that you do want to exclude underlying issues such as diabetes, vascular disease, and sometimes neurological disorders that are contributing to the situation. When it comes to those who actually need formal fertility treatment, the good news is that even in the setting of very low sperm counts, IVF can be effective. On the one hand, minor reductions in sperm count could still use conventional IVF, where we simply place the sperm together with the egg and incubate overnight. That can be the case if you've just got minor abnormalities of the semen analysis. However, if you have more profound issues with semen analyses, we can achieve successful fertilisation using ICSI. And ICSI is intracytoplasmic sperm injection, where a single sperm is injected directly into the egg. And we are forcing the fertilisation to occur in that circumstance. Also, for those with obstructive problems where we have to take sperm directly from the testicles via, for instance, a needle biopsy, we would always use ICSI, and it's very effective. For that subset of people who have really poor sperm morphology, and this is when really there's less than 1% normal forms, we can use the ultra high magnification ICSI or IMSI. And again, that just gives us much more detail. While standard ICSI can use a significant amount of magnification, it's really the ability to look inside the sperm and see very much more detailed information about abnormalities inside the sperm that helps with sperm selection. For those with non-obstructive azoospermia, there's many causes, mainly associated with a reduced production of sperm in the testicle. What a microtease is actually opening up the testicle and looking using a microscope to find the areas of sperm or areas of tubules that are more likely to be producing sperm. And this is in the knowledge that the testis is a three-dimensional structure, and there may be little pockets of areas that are producing sperm that, if sampled, are more likely to give a positive result than blindly sampling the testicle. It is also less harmful in terms of testosterone production and long-term harm to men's health. So we are doing a lot more of the microtease procedures. And again, we have very good surgical sperm retrieval rates of up to 50% for those with absolutely no sperm in the ejaculate. Finally, there will be some people who just don't produce sperm at all. They tend to be those who are associated with those more severe genetic problems. So in particular, certain microdeletions of the Y chromosome can be associated with a zero chance of being able to obtain sperm at the microtease. So it is important to have those genetic tests done before proceeding to that sort of more invasive treatment. For those where we can't retrieve sperm, New Life IVF, for instance, runs a donor sperm program. And of course, this is after exhausting all other options. Donor sperm is certainly an option that can restore the fertility on the male side. And so we've come to the end of our presentation. We have a number of questions that have come in already, and I'll just encourage anyone who has any burning questions to email them in. And so the first question that came in earlier was, what is the value, if any, of a DNA fragmentation test? And whilst I mentioned this earlier, really it is, I think, an extra test that may give a little bit more information, particularly when there's been repeated IVF failure, where the conventional testing hasn't really yielded an answer. The only caveat to that is the treatment for high DNA fragmentation is all of the things that we should be doing anyway. That is maximising those lifestyle changes, getting as many antioxidants in the diet, ideally with those fresh green leafy vegetables, all different coloured fruits and vegetables. You get lycopenes in your capsicum and tomatoes, etc. And all those supplements that we mentioned earlier that can help with in terms of the antioxidant supplementation. But for patients who repeatedly have failed blastulation, there may be some merit in running the DNA fragmentation test, just because those patients then would utilise more advanced sperm selection, such as HA-ICSI, which specifically selects sperm for their lower DNA fragmentation. Next question is, are day 3 embryo drop-offs due to sperm quality? That's a slightly harder one to answer, simply because there's so many factors that determine the progress of embryos after the day 3 stage. In general, the first couple of cell divisions are driven by the egg. So, for instance, really the embryo, regardless of the quality, can get to the 8th cell stage, which is your day 3 stage. The post-zygotic genome takes over at the day 3 stage. So the combination of sperm and egg is what's driving those further cell divisions. So abnormality in chromosomes is the classic reason that embryos fail to progress between day 3 and day 5. So could that be from the sperm side? Yes, potentially, although we know that egg quality is a much bigger driver in the setting of embryo progression, and we also know that the egg is a greater contributor to those chromosomal abnormalities. So I would say, in general, the egg has a more profound impact on progress of the embryo after day 3, although there is some evidence that using those more advanced sperm selection techniques, such as HA-ICSI, may improve blastulation in those who have had repeated failures. I think I'm going to hand over to Hugo now for a couple more questions.
Thanks for that, Samir. Some great questions and answers there, so do keep them coming through. So I've got 2 questions here. So is sperm really normal if the basic sperm test comes back within normal parameters? So there's two things first in that. So within the normal parameters, we normally give the lower end of the normal range. So for instance, a sperm count is considered normal if it has over 15 million sperm per mil, but we see huge variation. Sometimes there's 5 million per mil, some men have 100 million per mil. So normally the cutoff that we give is the lower end of normal. It's sort of the 5th centile. So whilst you're just above that, that doesn't make things good. You want to usually have things as high as possible. So, for instance, count where 15 million is the cutoff. A normal, healthy male will probably have a count of around 50 to 60 million. Where morphology, being how many of them, or form, so how many of them actually look normal, the normal cutoff is about 3 to 4%. A good, healthy number is probably something around the 10% mark. And in terms of motility, so how many of them moving around or moving in the right direction, usually the number is 35, 40 or so percent, but a good, healthy number is probably 70 or so percent. So whilst your numbers can be within the normal range, there is even within there a good and bad number. Now, with that said, I often say to patients, look, we only know what we can see. It's a pretty simple test, the semen analysis, and we can only tell what we can tell from it. If it looks good, it has great numbers, great quality, it could be in the hundreds of millions. It doesn't mean that it's a guarantee that these are fine, because often you have patients where the lady has no issues either. The tubes are working and the sperm looks fantastically good, but none of it's coming together. And sometimes we don't realise things aren't working until we put sperm with the egg in the lab. And then we realise that the sperm doesn't do anything or doesn't penetrate the egg. So we can only tell so much from a semen analysis. If the numbers look good, then we assume that they are good, but there's still a lot of information. We don't know the DNA status of it. We don't know how the DNA is packaged in the sperm. We don't know if there's anything missing or if it's damaged. So there's still a lot that we don't know. The good thing is that there's usually hundreds of millions of sperm, so an egg has many sperm to pick from. So another question, how well does sperm freeze for later use, and how many vials would you need for one cycle? Well, there's many sort of ways to answer this. So, generally, if you have it depends the reason that you're doing in the first place and what technique you're going to use. But generally, if you've got a normal semen analysis and you freeze it because you're trying to save some for later, or you're doing you're a sperm donor, or you want to have a backup of sperm. If the numbers are normal, when we unfreeze them, they won't be the same. The sperm number always falls because there's always sperm that don't survive. But generally, the amount that is unfrozen, those counts are fine to be used. Obviously, if you're starting with really, really low numbers because you've got a very low count for some reason, there's going to be less to unfreeze. And therefore the sperm that survive are going to be lower. And if you're in that type of situation, they're possibly going to be of a lower quality anyway, and they may not survive the unfreezing. In the end, how many unfreeze isn't normally an issue, because if there's only 10 eggs, the reality is we only need 10 really good sperm, and we're normally dealing with sperm, we're dealing in at least the hundreds of thousands, if not the millions. So it's really unlikely that unfreezing a sample of sperm generally is going to end up in nothing being able to be used for fertilisation. The only times that this is an issue is when you're dealing with really, really low numbers at the start. As for the question of or the part about how many do you need for a cycle, well, if there's 10 eggs, you need 10 good quality sperm. When we freeze sperm, we don't freeze it in one batch. Depending on the concentration and the quality, we freeze them in things called straws. So we break down the volume into multiple straws, and usually one straw is enough to do one cycle of IVF, because there'll be hundreds of thousands in that sample. So it very much depends on what technique we're using and what we're starting off with in the first instance. And our third question: Do supplements help men with obstructive azoospermia? Well, obstructive azoospermia. So azoospermia is a sort of medical term to say no sperm, and obstructive just talks for the cause. So it's saying that those tubes that I discussed earlier, the 800 metres or so worth of tubes, that there's a blockage somewhere for one reason or another, and the sperm can't get through. Now, we're assuming that on the testicular side that there actually are sperm. So that's one of the things that needs to be confirmed. And one way you would know that, say you'd had a vasectomy, but you'd previously had children, so clearly there are sperm there. We've caused the obstruction by cutting the vas. But the first thing is to make sure that there are sperm on the other side of the obstruction. Whether you have supplements or not is not going to reverse this situation, because it's usually a physical situation. Either there's a bit of the pathway that's missing, or it's damaged or it's blocked. So it doesn't matter how many supplements you take, it's not going to improve that particular situation. However, we do need to make use, if there's sperm there, we do need to make use of that sperm. And so we want it as high quality as possible. So in the same way that multivitamins, antioxidants, and the men's supplements will help a semen quality, it will also help the semen that is still within the testicle. In fact, the sperm that is in the testicle, especially if it's got a blockage, often builds up, and you can get an increase in antibodies as the body, I suppose, attacks the sperm that's stored there. This is probably a situation, and that partly is demonstrated by poorer DNA quality and DNA fragmentation, as Samir mentioned. So this is probably a good situation to use a men's multivitamin to do all you can to make sure the sperm that is there is of the highest quality possible. Samir, do you have a follow-on? Samir's sort of just coming, yeah?
Sorry,
A few more. So Samir's got a couple more questions. He's just coming on with those.
Alrighty, yeah, we've still receiving more questions, and these are some excellent questions. So the next one I'll answer is about the COVID vaccine and the effect on sperm DNA. We don't have any evidence that the new mRNA vaccines affect sperm DNA in any way, and that's partly because the testicles themselves are shielded through the blood-testicle barrier from the general immune system. We do know, however, that catching COVID has a profound effect on sperm quality that lasts for at least 6 months. So whilst these vaccines haven't been around for very long, the initial data from the last couple of years that they have been utilised, particularly overseas, is very reassuring. And we certainly know that catching COVID is very bad for your sperm. So highly recommend having your vaccination. The next question, does New Life IVF use PIXI? Yes, absolutely. We have access to the HA-ICSI, which is the more broad term for the PIXI specifically, and it's something that we do use routinely for those with high DNA fragmentation on their testing, or those who've had relatively poor fertilisation or blastulation in previous cycles. So absolutely we have access to that. What else can you do to test it if the female has been extensively tested? Well, certainly we can do the advanced sperm testing. We'd want to make sure that the male side in particular karyotypes have been tested. Sometimes where we really don't know what's affecting sperm quality, there is the option of doing a surgical sperm retrieval. In particular, the needle testicular retrieval can be associated with retrieval of sperm with less DNA damage. And the reason for that is that the whole process of sperm entering into the seminal fluid and being ejaculated is one that's associated with the accumulation of damage, oxidative stress to the sperm. So considering a surgical sperm retrieval for fertilisation is actually one of the things we do consider when all of the tests haven't been revealing of a problem or guided us as to what specifically is the problem, and in particular those with high DNA fragmentation that doesn't come down with supplementation or has no success with HA-ICSI. The next one is actually a very complicated question. Why do some eggs not fertilise? Well, fertilisation is clearly the interaction of two gametes. It's the high quality sperm being able to penetrate the egg and affect fertilisation. So factors on both sides can affect fertilisation. So clearly if you're doing standard insemination and the motility of the sperm is suboptimal, the sperm can't physically swim to penetrate the egg, and that can result in a failed fertilisation. ICSI can overcome that in the setting of failed fertilisation and low sperm motility. interestingly, when you look at the volume of the sperm and the egg is magnitudes larger than the sperm. So high quality eggs can somewhat compensate for lower quality sperm because there is actually DNA repair mechanisms inside the egg. Unfortunately, the opposite isn't true, that low quality eggs can't necessarily be overcome by high quality sperm. So to some degree, it is the combination of the two. A lot of fertilization is driven by egg quality. And so sometimes even in the setting of really good sperm, very normal sperm parameters, normal DNA fragmentation in a healthy man, we do see suboptimal fertilization rates or failed fertilization that does have more to do with the quality of the eggs. And unfortunately, the quality of the eggs is a little bit harder to influence, although different combinations of medications and different combinations of supplements for the female may be an option. The last one that I have is, apart from lifestyle change, is there any particular vitamins and supplements or food that a man can take with extremely low and unhealthy sperm that can help boost the number and motility, etc.? So it does come back to what we did discuss about a healthy diet, in particular trying to get as many antioxidants as possible through the diet. So I do prefer that people do try to obtain their antioxidants through the diet. So fresh vegetables, lots of different coloured vegetables. The different colours are associated with antioxidants. Berries are excellent, blueberries, all of those things are very supercharged with antioxidants. The supplements that we discussed are very important for those with poorer sperm counts, and ultimately improving your health as much as possible is the best we can do to reverse any damage to sperm quality and quantity. If that still doesn't occur despite all those changes, that's where we're talking about things like IVF, ICSI, surgical sperm retrieval, IMSI as well, and the HAXI or PIXI. That is all the questions I have, and so I'm going to hand back over to Hugo.
Again, excellent questions coming through, and Samir showing his brilliance as always. I've got three to discuss. So the first one is, if embryos make it to a hatching blastocyst, is that a good sign that the egg and sperm are okay or good enough? Well, a hatching blastocyst is always an excellent place to get to because it's rather progressed in the sort of in the life cycle of an embryo, and it's not far off when we would be looking at transferring. So every time an egg continues or an embryo continues to grow and moving forward, that's always a good sign. And the reason for this is that as time goes on, those lower quality embryos where there's damage, where there's DNA issues, where it just hasn't come together, they tend to die off. So it's a little bit of natural selection. So the more that an embryo moves forward, the closer to day 5 we get, the more likely it is to survive and to implant. That said, we also know that not all embryos, even the ones that are grade A and are on day 5 and look brilliant, they're not guaranteed that they're normal, and they're not guaranteed that they're going to take. So we know that even those embryos have, when they're sent off to be genetically tested, are going to be abnormal. And we know this because through testing, but we also know that we can transfer what look like brilliant embryos and the patient miscarries, and when we test it, it's abnormal. We also know that patients who have Down syndrome, children with Down syndrome, that obviously even those embryos can progress through to birth. So yes, it's a great sign, but it doesn't guarantee that it's completely normal. Does it have any does this tell us anything about the egg and sperm? Well, it says that those were probably a good egg and good sperm combination. So the next question is, do you recommend ICSI if sperm is normal in women over 40? So I think there's two bits to this question. So it's a bit hard to, without knowing more about medical history, it's very hard to make a sort of a call on this. And I'll divide it into two bits. So ICSI versus normal so IVF, so just putting some sperm with the egg and letting nature fertilise. So the first thing is that ICSI is not necessarily better than IVF. In any normal situation, IVF is a very, very good technique. ICSI is usually only better if there's a need for it. And the main cause is because there's abnormal sperm parameters, the counts are low, the number of normal forms are low. Another reason is that you've tried IVF before and you've had very low fertilization rates. So that's a good reason to use ICSI. If the overall counts, if you're not working with many sperm, then that's a good reason to use ICSI. Previously, but not so much now, although it is still for some genetic techniques, but previously when we did genetic testing, we had to ensure that there was only one sperm and one egg. Now, there's nothing wrong with those sperm or that egg. It was a necessity because of the testing that we were doing. So there are reasons why you would do ICSI. Do you do ICSI because it's better? Generally, no. It's only better if there's an issue or a reason to do it. My general comment is the more we interfere with embryos or eggs, the more we touch, the more we do things to them, the more likely we are to stuff things up and to lose embryos. So the less that you do, unless it's necessary, I think the better that the embryos are. If we bring it back to the component of women over 40, well, there's no real reason why over 40 should use ICSI versus not. You decide on the parameters that I've given you, but then you also decide on quality. So, there are some patients who are over 40 have brilliant, excellent looking eggs, and, they may do very well with natural, they may do very well with ICSI, but there are those women over 40 who have eggs that are really poor quality, and we know that if we do ICSI and try to put a needle into it, that we're going to rupture the egg, and it's going to die. So it's hard to give an answer to that, other than to say, ICSI is only better if it's needed. You don't just do it for the sake of it. And then the last question that I have is, how many days before IVF cycles do you suggest waiting before giving a sample? So with New Life IVF, we have a sperm bank, and we also have obviously facilities for storing sperm. And on the back of our pamphlet, there's good instructions on what to do before presenting. Generally, we recommend that you should save up for about 3 to 4 days, probably no more than 4 days. After that, sperm are starting to get a bit old and are starting to die off, and any less than that, the count is going to be low, and you're not sort of giving yourself the optimum chances. So sort of 3 to 4 days. In some instances, we'll recommend that you either masturbate or have sex leading into this, just to clear out the pipes, so to speak, and start with a clean, fresh batch of sperm. In some situations, if you've had an IVF cycle that's been unsuccessful and we've been a bit sort of dubious of the quality of the sperm, sometimes we'll actually give you instructions to masturbate every day for 2 or 3 days leading up to the day that the sperm is required, just so that we're really clearing out sperm and have a sort of a really good fresh batch to use in the lab. So generally 3 to 4 days is the answer to that question. Some more questions? I think we do. So Samia's coming up with, I think, the last batch of questions.
We have our last couple of questions coming up. So the next one I have is, why would HA-ICSI produce a lower fertilisation result? Now, just to be, clear, HA-ICSI is simply a way of selecting sperm. It doesn't change the individual sperm, and often it is used where the quality of sperm is slightly lower. So the underlying sperm quality is the real determinant of fertilisation. If anything, I would expect once you use HAXE, all things being equal, and you do select the best sperm in that batch, we ought to get better fertilisation, although that's not universal. Okay, the final question I have is, how can stress affect sperm? So, in general, we know couples who are under a lot of psychological stress have a slightly lower chance of pregnancy. But it's unusual for psychological stress to cause a major reduction in, or irreversible reduction in, sperm count. We know that any sort of physiological stress, that is intercurrent infection, any other illness, definitely causes a reduction in sperm count that is temporary, and usually that recovers 6 to 8 weeks down the track, and that is why we recommend the repeat semen analysis, at least that interval, to make sure we determine whether it's a temporary or ongoing factor. All right, well, that takes us to the end of our presentation and the end of our questions. We had some fantastic questions, and if there are any more, you can always email our Newlife at Newlife IVF, or speak with one of our fertility specialists. In terms of our next presentation in this series, that's going to happen on the 7th of December, where my colleagues Dr. Nicole Hope and Dr. Chris Russell will be speaking on the topic of I want to be pregnant by the end of 2021, but I'm not. What can I do differently next year? We hope you'll be able to join us then.